All right, welcome to my presentation on myasthenia gravis. We're going to be looking at a case study in myasthenia gravis, which is an autoimmune disease. So, myasthenia gravis will abbreviate as MG. This primarily happens due to an autoimmune attack of the acetylcholine receptors. And that can also, it can attack muscle-specific kinase. We'll just call that MuSK. But most commonly it's acetylcholine receptors. And both of those are located in the neuromuscular junctions. We'll talk more about that later. When that happens, there's a decrease in the signal transmission and resulting in a decrease in muscle response. This can happen in any striated muscle, with facial and extraocular muscles being the most common. It can even progress to respiratory muscle weakness and paralysis, but that's in really severe cases. And the facial muscle weakness is most commonly seen as ptosis. And so that's, as a physician, that's what we want to look for. Now, pain or numbness is abnormal in patients because it affects the motor nerve pathways and not sensory nerve pathways. And so it's also noted that muscle weakness is generally worse after prolonged use, and we'll get into that a little bit as well. So a little bit of history about myasthenia gravis. So it's an autoimmune nature, the autoimmune nature of myasthenia gravis was demonstrated by Patrick and Lindstrom around 1970 when they injected rabbits with purified acetylcholine receptor. And the rabbits quickly developed antibodies and their ears got floppy. Well, the floppy ears that we see resulting in the rabbits is actually similar in nature to what we see in humans in the ptosis aspect, which, if you're not familiar with ptosis, that's the drooping of the eyelids. So let's look at the normal function of acetylcholine receptor in a neuromuscular junction. So acetylcholine receptors are found on the postsynaptic membrane, and when they are bound to acetylcholine, which is their ligand, they send a signal to the muscle cell telling it to contract. Now, the neuromuscular junction is actually very, very small, nearly microscopic, and it needs to have a very high density of acetylcholine receptors in that area to function effectively. Now, the density and clustering of those acetylcholine receptors is created and maintained by MuSK. The clustering of that acetylcholine receptor gives the most efficient response to the least amount of acetylcholine released from the presynaptic neuron. Now let's look at myasthenia gravis effect on acetylcholine receptors. So most commonly, the plasma cells release IgG1 and IgG3, and these plasma cells are licensed by self-reactive T cells that survive negative selection in the thymus somehow, some way. And these antibodies bind to these acetylcholine receptors and render them inactive or ineffective. Sometimes they even trigger opsonization. Actually, that's not super uncommon. And in more severe cases, even cause complement-mediated myocyte lysis. Say that 5 times fast. And so in that case, it's more severe because even when you have, if you're able to correct the issue, which we're going to see later on some ways you can do that, if you have myocyte lysis, you have destroyed your neuromuscular junction. And so therefore, you are now at a major disadvantage, and that may even render that completely ineffective. Let's look at the effect of myasthenia gravis on the agrin-MuSK pathway. So when you get a more severe case of myasthenia gravis, it can target the agrin-MuSK pathway. And the overall result of that targeting is very similar to when you have acetylcholine receptors being inhibited or removed. And the motor signal obviously doesn't transmit effectively anymore across the synapse. So agrin is secreted by motor neurons. It's an extracellular protein. It binds and activates musk. And musk then begins clustering acetylcholine receptors into the neuromuscular junction and maintains their density. So it not only initiates and helps with clustering, it also maintains their clustering and their density. Now, when you get anti-musk antibodies in myasthenia gravis, it is more severe than the anti-acetylcholine myasthenia gravis because there's no clustering of acetylcholine receptors at all in the neuromuscular junction from the beginning. So, therefore, it's going to be a little bit more severe because even when you don't have as many antibodies floating around, you might not even have a decreased number of acetylcholine receptors, but they're not concentrated. And so therefore you can be releasing as much acetylcholine as you want into that synapse and you're not going to get a response. So the heritability of myasthenia gravis is actually interesting because we already looked at that it secretes IgG antibodies. And these IgG antibodies actually can pass through the placenta from the mother to the fetus. So myasthenia gravis can actually pass to offspring through placental circulation. However, after that indirect connection between the mother and the fetus is severed at birth, the infant begins making their own antibodies to replenish theirs and to replace what they got from their mom. And most to all antibodies that they got from their mom are replaced within the first 3 to 4 months. And so, therefore, if there's any myasthenia gravis symptoms at birth, most of those regress completely by 3 to 4 months after birth. Now, there is a mechanism of progressive muscle weakness in myasthenia gravis. So we looked at that it is characteristic to have a progressive muscle weakness, but here's the mechanism of it. So generally, as the day progresses in these patients, the muscle weakness gets worse and also improves after they rest. So in the mornings, it's better. So let's look at this example of when you have acetylcholine receptor antibodies, anti-antibodies. And so there's a decreased number of these acetylcholine receptors. And also, interestingly, with each repeat nerve stimulation, there is a decrease in release of acetylcholine. So basically, for every nerve stimulation you get, there's less acetylcholine released into the synapse. And that combined with the decrease in acetylcholine receptors leads to that progressive muscle weakness. So here's a case that I saw. I had a patient come in with a chief complaint of intermittent diplopia that was progressively worsening over the past 4 months or so. Otherwise, he says he's healthy. On examination, I found he had very significant ptosis where the upper 1/3 of his iris was covered by his eyelid, both sides. Limitations in his ocular movements as well on both sides. He couldn't, when I had him look left and then look right, he couldn't look left and right very well. So he had extraocular muscle weakness. The rest of his neurological exam appeared normal. I had my radiology team do some tests, and we found no thymus enlargement. And then we took a blood sample and did some blood testing and found that he had anti-acetylcholine receptors at levels of 6.88 nanomoles per liter, obviously in reference to normal, where it's less than 0.5 nanomoles per liter. And so I prescribed him pyridostigmine, which is a cholinesterase inhibitor. And the results really, he improved quite well, quite quickly, and steadily. Unfortunately, though, he wasn't able to tolerate the full dose of pyridostigmine, only about a quarter of it, and it wasn't efficacious. And so 3 years later, this patient came back and he had significantly worse ptosis, and that was actually secondary to he had just gotten over a severe respiratory infection. His diplopia had returned. He wasn't able to speak intelligibly. He actually was having difficulty chewing and swallowing, was on a strictly soft diet only. I want to just take 1 second to address why was this uh, resurgence, why was this flare up caused by this respiratory infection? Well, interestingly, when you have an infection, an active infection going on, you actually increase the ratio of your B and T cells compared to your regulatory cells. And so therefore it can cause a flare up of these autoimmune type diseases. Um, Back to my exam, though, I actually found that on this visit, his facial muscle and tongue weakness was back, tongue weakness even more now, and decreased ocular movements now as well, still. Uh, and they were back. He was also having difficulty breathing and a decreased vital capacity that we found at about 3.5 liters, with the normal reference being around 5 liters. And so I knew this was a serious situation and we had to act on this. And so I went ahead and admitted him, and I administered azathioprim, which is a potent immune suppressant. And turns out he we got pretty quick results, actually. His diplopia and ptosis notably improved. His eating and vital capacity returned to normal. We actually measured his vital capacity at 5.1 liters, so that was great. Really encouraging. About the treatments in general of myasthenia gravis. So first of all, if the patient shows symptoms of myasthenia gravis, then you need to confirm the diagnosis by testing their blood for anti-acetylcholine receptors and anti-musk antibodies. As well, if there's other antibodies that you suspect, whatever, you can test those as well. But with normal levels for anti-AChR being less than 0.5 nanomoles per liter. Now, the first line of treatment is acetylcholine esterase inhibitor. As an example, the one I prescribed him, but it decreases degradation of acetylcholine within the synapse, leaving more acetylcholine present to bind any residual acetylcholine receptors, which is great. That's a great good start. It does have some side effects, but it is fairly effective if they can tolerate the dose. Second line of treatment, if they can't tolerate the first line of treatment, and if the symptoms are progressing and severe enough to be life-threatening, then this is another option. This is an immune suppressant, and this is the one I prescribed for my patient when he couldn't tolerate it. And it basically targets removing all of the B and T cells. So it ends up removing those self-reactive antibody-producing cells. And that's a benefit, but also a high risk, because literally, remember, you're removing all their B and T cells. You are basically removing their adaptive immune response. So proceed with caution. Make sure you weigh out the risks and benefits of this. So let's look at some correlations. It's been found that more than 50% of patients with anti-acetylcholine receptor myasthenia gravis have a thymic hyperplasia, and 10 to 15% have thymomas, which are like a tumor of the thymus. And those patients with thymomas, they actually resulted in a decreased expression of AIR transcription factor, and a decrease in also regulatory T cells. Now, the normal function of AIR is to upregulate as many genes as possible, a bunch of genes in the thymus cells, the epithelial cells there, to express more self-proteins that are not normally expressed in the thymus. And it does that for the purpose of negative selection of T cells. Regulatory T cells, they actually function to cause self-reactive B and T cells to undergo clonal anergy, and basically renders them ineffective. So when you have a deficiency in these, you can see how that can cause a significant impact and could definitely lead to and correlate with myasthenia gravis. Now, when we understand myasthenia gravis as a disease, it helps us understand the treatments. So azathioprim can be therapeutic to get severe symptoms under control. But remember, it can have super bad side effects since it's such a potent immune suppressor. So make sure if you're going to use this drug, make sure you weigh out the risks and benefits with your patient. So to conclude, myasthenia gravis presents as a progressive muscle weakness and generally is due to an autoimmune attack on acetylcholine receptors. That's the most common, but we definitely saw some others as well. It does have varying ranges of severity. So without treatment, it's likely to result in death by asphyxiation because it's going to lead to respiratory muscle weakness. And it's important to confirm, before you treat, it's important to confirm the diagnosis by blood work to avoid any unnecessary treatments or off-target side effects. Make sure you do that. That's critical. And then make sure that you inform your patients of the different treatments and discuss the best plan of action to make sure that you are working on this together and that they can work with you to discuss and understand the risks and benefits of this, and then you can work and move forward together on a best plan of action. So here are my references, and thank you for listening.